Thank you very much for having us, and more importantly, thank you for being here. We hope to, during this next hour and a half, to discuss this important topic. I would like to introduce Dr. Kelly Epps, who is the director of the Women's Heart Program. She's an interventional and structural heart cardiologist, and she will kick this off.
Good evening. Thank you all for coming today. We're going to start off talking about heart disease, and we'll talk about how signs and symptoms differ for men and for women. So the first question we'll answer is, what is heart disease? So I have many patients who see me in clinic, and at the end of our visit, their question is, do I have heart disease? And heart disease is a term that's an umbrella term. There's a lot of different types of heart disease when we refer to it. So I will give you a sense of what we mean when we say heart disease. So the most common form of heart disease is coronary heart disease or coronary artery disease. That is atherosclerosis or plaque buildup in the heart arteries. And that's the type of disease that we most commonly think of as heart disease. That's what leads to heart attacks. That's about 44% of heart disease. But there are many other types of heart disease or cardiovascular disease. One of those is stroke. We also think of heart failure as a form of heart disease, high blood pressure as well, diseases of the arteries, that can be diseases of the aorta, the big blood vessel that goes from the heart to the rest of the body, or disease in the legs or in the arteries in the neck, the carotid arteries. And then there's a category of other things that would be things like heart valve disease or irregular heart rhythms like atrial fibrillation. So how prevalent is heart disease? Heart disease is actually a very prevalent disease. And you can see here, by the time that patients get into their 60s and 70s and 80s, most patients that age actually have some form of heart disease. The average age, the average age for first onset of a heart attack for a man is about 65 years old. For women, it's a little bit delayed, and women tend to develop heart disease about 10 years after men do, and we start to see a rise during menopause. The average age for the first heart attack for a woman is 72 years old. But you can see here that still patients in their 40s and their 50s, they still can have heart disease, and so it's something that we should all be aware of. Heart disease not only is prevalent, it's actually a very deadly disease in both men and women. It is the #1 killer of men and women in the U.S. And you can see here, we list the top causes of death. And heart disease is #1 for men and women, followed by cancers. And this is all forms of cancer combined. Heart disease is more common. There's actually a misperception, though, that women aren't as high of risk for heart disease as men are. And the American Heart Association has done surveys over several years of women to ask them, what do you think your greatest health risk is? And we really learned that women really didn't think heart disease was a great risk for them. Most of them thought that breast cancer was a greater risk than heart disease was. But we know that 1 in 30 American women dies of breast cancer. 1 in 3 American women dies of cardiovascular disease. So it really is much more prevalent and more deadly. In the early 2000s, we saw a lot of awareness campaigns as we were starting to realize that women really weren't aware that this was a risk for them. So the NIH, or the National Institutes of Health, the American Heart Association, and other organizations put together campaigns to raise awareness so that women knew that they were at risk as well, and then also for women to really advocate for their heart health. And we could see this is the multiple surveys that were done from 1997 to 2012, and you can see that these campaigns to raise awareness were working. We see that the number of women that recognized that heart disease was the leading cause of death for them increased over time. But we still see that it's only about 50% of women who think that this is their number one health risk. And when you ask women, do you think that heart disease is something that can affect you? Really, only 1 in 5 women perceive that it's something that affects them. So there's still some work we have to do in terms of awareness, and part of this type of session is for us to engage with you and answer questions about that. We look at the mortality trends for men and women in the United States from heart disease, and we actually do see that there is a decline in mortality. And part of this is due to the wonderful awareness campaigns that we've had. Other reasons why we see this decrease in mortality, is the research. We've had a lot of research that's been done on medications for blood pressure and medications for cholesterol during this time period. There's also been public health pushes to reduce smoking. And we can see here that there's been a decline in both men and women. At one point, women had worse outcomes than men for about 3 decades. From 1984 to 2012, women actually had more risk of death from heart disease than men did. But we started to see in 2012 that those curves came together, and it was about equal risk of death for men and women. So what are the risk factors for heart disease? We think about risk factors in 2 categories. One is things that we say are non-modifiable, things that you can't change. They are things like your age, your sex, your family history of heart disease is very important. And then also your race or ethnicity can play into your risk of heart disease. So it's important to know these, although you can't modify them. It's important to know so that we can know, are you somebody that we should be more aggressive about trying to control your risk factors and in the future. We also think about modifiable risk factors. Those are things that you can do something about to decrease your risk. So our modifiable risk factors, and these are risk factors for both men and women, they're the same. 1 is cholesterol, 2 is elevated blood pressure. Also, elevated blood glucose or diabetes is a risk factor that we can modify. Our level of physical activity, so physical inactivity is a risk factor for heart disease, overweight, and tobacco use. And as I mentioned, these are risk factors in both men and women, but we do know that some of these risk factors confer greater risk in women than men. So women who smoke, women who have diabetes, those risk factors are more dangerous for women than they are for men. We also know that there are some risk factors that we think of as female-specific risk factors. And these may be risk factors you haven't heard of as frequently as the ones we've mentioned. These are things that we consider the non-traditional risk factors or emerging risk factors. They are risk factors that we're starting to learn more about with research, that this really does impact a woman's risk in the future. That's things like pregnancy-induced complications, so women who have had a history of preeclampsia or gestational diabetes, high blood pressure during pregnancy, or even preterm delivery. We know that those women can be at significantly greater risk for heart disease in the future when we look 10 to 15 years after these pregnancy complications. We also know that autoimmune diseases like rheumatoid arthritis or lupus, those are diseases that can happen in both men and women, but they're more prevalent in women than men. And those are risk factors that increase your risk for heart disease. And some rheumatologists feel that most patients with rheumatologic disease should be seen by a preventive cardiologist and really work towards decreasing their risk. Breast cancer treatments are also a risk. So these are life-saving treatments for breast cancer, like chemotherapy or radiation therapy. But we also know that these treatments are cardiotoxic to the heart, or at least have potential toxicity to the heart. And so we get concerned that those patients can develop heart failure. They can also develop coronary heart disease or blockages in heart arteries. They can develop valvular heart disease down the line as well as a complication of these treatments. So these are patients that we monitor as well. Also, we know that, that depression and stress are risk factors, and we see this particularly in women. And then also menopause is a risk factor for women. It's not that menopause causes heart disease, but we see many of the many of the traditional risk factors like blood pressure and cholesterol, those increase during menopause. So those go up with age, and that places women at greater risk after menopause. What are the symptoms of a heart attack? So the most common symptoms in both men and women are chest pain or pressure. That's probably the most common symptoms that patients notice. They also complain of upper body pain or discomfort, including pain in the arms, in the neck, in the back, or the jaw. And then sweating is also a common sign. But symptoms of heart attacks can differ in men and women. While men and women both have those more common symptoms, we know that women are more likely to also have more subtle symptoms. And so there are other symptoms that they may have that are a sign of a heart attack too, that it's important for women to be aware of, and men as well, but they're more prevalent in women. And so what are these symptoms? These are symptoms like shortness of breath, unusual or unexplained fatigue, lightheadedness, dizziness, nausea, or abdominal pain. Some would even say they're flu-like symptoms. They may not even consider that the symptoms they're having are due to a heart attack. But what we do know, and this is from studies that have specifically looked at women who have had heart attacks and asking them questions about what are the symptoms that they had before the heart attack, chest pain was actually absent in 43% of the women. So almost half of the women didn't have any chest pain as their symptom when they presented with their heart attack. Some of the most common symptoms were shortness of breath. That was in about 58% of women. Weakness is another symptom, which is fairly subtle or vague. Fatigue was a common symptom as well. And then also what we found is that women tended to complain of symptoms for even up to a month before having the heart attack. It's what we call a prodrome of symptoms leading up to the heart attack. Symptoms like sleep disturbances, shortness of breath, fatigue, and anxiety. And so why might women have some of these differences in terms of the symptoms and in terms of their presentation when they have a heart attack? We do know that there are some biological differences between men and women. We know that women's hearts have some differences compared to men's hearts. One is that women tend to have smaller heart arteries than men, and that's probably related to the fact that they usually have smaller stature. We know that the way that women deposit plaque in their arteries, it tends to be more diffuse, meaning they tend to spread it out all along the artery rather than having it localized to one place in the artery. So we would say women have more diffuse disease, men have more focal disease. This is on average. And then there's also a saying that when women have a heart attack, they erode, whereas men explode. And this sort of describes what happens when they're having a heart attack. Women, they tend to have this erosion of the lining of the artery. We see that more often in women than in men, where they actually will have a plaque that ruptures, and that causes a sudden blockage in the heart artery to cause a heart attack. And now I'm going to have Dr. Tehrani take over. He is our director of our cardiac catheterization lab here at Inova Fairfax Medical Campus, and he's going to talk to you about a case presentation.
Thank you very much, Dr. Epps. So, as Dr. Epps just showed, cardiovascular disease is something that we are all very vigilant when we take care of patients in the cath lab. 100 years ago, in the early in the 1900s, you were more likely to die from pneumonia or TB or typhoid than heart disease. And we've become much more prevalent, and we've become much more vigilant in understanding the prevalence of this disease. And so this patient that I will show you is a case of somebody that had what we call a myocardial infarction or a heart attack. But these things happen 1 in every 40 seconds. 600,000 people a year have some form of heart disease, and this particular form is the one we'll talk about. So this is a patient, a 45-year-old woman, who has some of the typical cardiovascular risk factors that we think about. High blood pressure, what we call essential hypertension, high cholesterol or hyperlipidemia, diabetes, and even lupus, an inflammatory autoimmune disease, which does carry adverse cardiovascular risk. She comes to the hospital with 2 hours of what we would initially think of as more atypical symptoms: back pain, abdominal pain, sweating, and then when she is seen by the emergency room physician, she's complaining of some chest pressure. And her EKG, which is a nice strip of paper with a bunch of squiggly lines on it that we always look at, shows what is concerning for a heart attack. She's taken emergently for a cardiac catheterization, and as many of you know, cardiac catheterization is a procedure that's done percutaneously, meaning it's done via small catheters, 2-millimeter catheters, more oftentimes in the wrist, but also from the groin. And we take small little tubes up into the heart, into the aorta, and through those tubes we then inject dye, iodinated contrast, that then opacifies these arteries and lets us see if there's a blockage. So as Dr. Epps mentioned, men's blockages are more often time because there's a plaque that's ruptured and there's clot attached to it and there's a blockage. Women, especially before menopause, they will develop a plaque-style erosion. And these pictures are taken via X-ray tubes, and we're able to take a look and see what the patient had. Got it. So this artery here is the right coronary artery. It's the artery that comes off the right side of the heart. And as you can see, the catheter is engaged, and before even the dye is injected, you see some clot that's just sitting up there. And that signifies a plaque that's eroded, and then there is attachment of clot to it. And, with just a manipulation of very thin and fine wires that are 0.014 inches, we then thread through that blockage, and we then do what's called a balloon angioplasty. These are small 2.5 millimeter balloons, which we literally buttress against the wall of the artery to get better blood flow. And that's where that balloon is. It's got little markers at the top and the bottom portion. And then, as you can see here, you start to get better blood flow. And in this area of haziness, you start to see where the plaque had likely eroded, a heavy clot burden that caused this heart attack to happen. And then, with the advancement of stents, which are essentially metal scaffolds on a balloon that are typically coated with drugs, or they can be metal coated, just pure metal instruments. We then inflate within that area of the blockage. And as you can see here, the final picture shows that there is restoration of blood flow. Initially, this patient needed a temporary pacemaker when they came in. Their heart rate was slow. They were in distress, but then with a final result, blood flow was restored. The pacemaker came out. She went up to the cardiac intensive care unit and left the hospital 48 hours later. So, and this has all been advances that have happened in the field of angioplasty now for over 40 years. The first angioplasty was done by Dr. Grunzig in Zurich. And typically if somebody came to the hospital, even for an elective intervention, they were in the hospital for a day or so before, several days afterwards, and patients could spend up to a week in the hospital. And now, as our folks here can tell you, this has become essentially, for lack of a better term, an outpatient procedure. They come in, they get their artery fixed, even in the setting of a heart attack. They get a good, durable result, and then 48, 72 hours later, they're going home and they're returning to their families and their previous engagements. So this is a picture before the stent. This is a picture after the stent. This patient did very well. She did not suffer any long-term consequences for a heart attack. She was put on guideline-directed medical therapy, and all of her risk factors were very aggressively treated. So when we think about, what is the best way to achieve ideal cardiovascular health, we think of, what we call the ABCs of cardiology. It's regular exercise. To maintain good cardiovascular tone and health, we recommend exercising 30 to 45 minutes, at least 3 to 4 times per week, if not more. And to actually lose weight and burn calories, we recommend even more than that. walking, aquatic exercises such as going to the pool, anything where you're able to get your heart rate up and to achieve good cardiovascular tone. Having a diet which is well balanced and it's low in the bad things that we think about, carbohydrates, saturated fat, high in proteins. Bringing our blood pressure down. So blood pressure is something that we call in medicine multifactorial, meaning that there's a lot of things that contribute to it. Stress plays a role, but also what we do to our bodies certainly plays a role. So what we eat, our weight, all the good things that we can do to maintain a good heart healthy lifestyle. Cholesterol, there certainly is a familial component. A lot of us will have elevated cholesterol because of genes that are passed on to us by our parents and our grandparents in the way that we are able to clear bad cholesterol, or known as LDL. But we can certainly do things to help mitigate that risk, and that includes eating a heart-healthy diet and exercising. And blood sugar. Blood sugar is really important. Elevated weight plays a role. The higher your weight is, that puts a toll on the body, and people can develop insulin resistance. And insulin is what causes blood sugars or glucose to be cleared from the bloodstream. And other things that we think about: smoking. Smoking certainly plays a role with regard to cardiovascular events. This is not like what it was 30, 40 years ago, where it was a fad, where you could look at a magazine article, or even if you look at old pictures, white and black and white from the White House, where you had advisors to the president smoking a cigarette. This is truly a health hazard that needs to be addressed with our patients. And so with the appropriate screening that we recommend for blood pressure, we say starting at the age of 20, because there are people that can develop early hypertension or early blood pressure, especially from other causes, thyroid disease, diseases of the kidneys and the adrenal glands. But really it's important to start early, because we know atherosclerosis or plaque buildup starts in the later adolescent, early adult years. So it's important to get your primary health visit done, get your blood pressure checked at least every 2 years, and try to meet your aggressive goal of 120/80. Get your cholesterol checked early, also at the age of 20, every 4 to 6 years, and make sure that you have that ideally managed. Blood sugar control is very important after the age of 45, every 3 years. And body mass index. Obesity unfortunately is an epidemic in this country, and if we're able to control our weight, control what we consume, it plays a large role with regard to reducing and mitigating that risk. There are a number of risk assessment tools that are available that we can use. This is available on the inovaheart.org/heart-risk-assessment website. We are able to calculate it. The American College of Cardiology has an application that you're able to easily upload onto your mobile phones. It's called CV Risk Assess, and it looks at a number of parameters: your age, your sex, the race, total cholesterol, good cholesterol known as HDL or high density lipoprotein, whether you're on blood pressure medicines, whether you smoke, and whether you're diabetes. And it gives you a risk assessment score, and your physician can then use that score to determine how aggressive to be with your risk, with your medicines, with cholesterol, and the other things that go into effect of mitigating and minimizing the risk of heart disease. The Harvard School of Public Health looked at the Women's Health Initiative study. They looked at over 100,000 women over the age of 50, and they saw that only 4% of women were in ideal tip-top cardiovascular health. And by undertaking good lifestyle modification measures, they saw that not only in women, but also in men, they were able to reduce that burden of risk by 80% in women and more than 60% in men. So the take-home point here is that heart disease is the most prevalent and the most deadly disease in men and women. 1 in 40 people will have a heart attack. Every 40 seconds, a man or woman will have a heart attack. The causes and the symptoms can differ, and that's why it's important to be vigilant and to understand that a man's symptoms may not be the same as a woman. But not only that, but the demographic profiles of each individual person can be different. Heart disease is indeed preventable. We, as physicians and as patients, we certainly have a role to play in working together to developing a partnership to mitigating that risk. And at the end, Dr. Epps will emphasize it as well, that we can be our own best health advocates. It's important to know your numbers. It's important that when you go see your physician, you have an idea of where your health is compared to where it was a year ago, 5 years ago, and 10 years ago. And it's important to take action and be proactive. Thank you very much. We will now open up the forum to questions.
One of the issues that I've run into personally is a war going in between my cardiac medications and my liver. How does one survive that?
Right.
I've decided to choose heart disease as a killer rather than liver failure.
So you bring up a very, very important point, and especially our heart patients can be on multiple medications. So we always do make sure that we are very vigilant about what are the side effects that you may be having from medications, and also how does it interact with other medications that you're on. When I think about issues with liver, I think mostly about cholesterol-lowering medications because the statins, right? Because that is one of the concerns with statin therapies is that while statins can do great things to lower your blood cholesterol and can also reduce your risk of having heart attacks in the future, there are side effects. The most common side effect patients complain of is muscle aches or joint pain. But the other thing that we worry about and monitor fairly closely is liver function as well. Usually what I do with liver function, depending on how elevated it is, I generally accept the liver function studies on blood work being elevated, but at least as long as it's less than 2 or 3 times what we consider the upper limit of normal, I usually say it's okay to continue it because that statin is very important for you. And although we may see that it's having some effects on your liver, we don't think it's very, very concerning or very dramatic. Certainly I have some patients who have a very significant response in terms of their liver function being compromised because of the statins. And in those patients, usually I send them to a liver specialist, a hepatologist, to help us manage both of those and decide what the best therapy is. And in some patients, it's that they just can't be on this type of therapy. And in those patients, we may stop it altogether, or sometimes we may try a different statin. We may lower the dose. Sometimes we even do every other day dosing to see what the patient can tolerate in terms of their liver function. There are some alternatives to statins. They're newer medications that have just been approved in the past, probably year to year and a half. They're called PCSK9 inhibitors. They're injectable cholesterol-lowering medications. They're not for all patients with high cholesterol, but there's certainly certain patients that we like to think about those medications in. And those are patients who, if we can't get your cholesterol level to our target range on the highest dose of statin, then we think about adding this injectable medication to it. Or in patients who can't tolerate statins and having the liver function test being elevated, that would be a patient who I might say maybe you can't tolerate it, and we should think about these newer injectable medications that help lower cholesterol because those, at least to our knowledge so far, don't affect the liver function in the same way. You're welcome.
Thank you. What is the current thinking on taking a baby aspirin for prevention after a certain age?
Mm-hmm. So we know that aspirin can be very important to reduce your risk of a future cardiac event like a heart attack or a stroke. But aspirin is not meant for every patient because we know there are side effects from statins as well. The most important side effect we worry about with aspirin is bleeding. And so that could be gastrointestinal bleeding, that could be or intracranial bleeding or bleeding in the brain or the head. And there was actually a recent study that looked at that to see what are the risks of aspirin therapy versus what are the benefits of aspirin therapy. What it did show is that it reduced your risk of having some type of heart event or stroke by about 12% by being on a baby aspirin. But it does increase the bleeding risk, as I mentioned. So currently what our guidelines would say, the U.S. Preventative Health Services says that for women, we think about it, once we start thinking their risk of heart disease is becoming more elevated because we're weighing risks and benefits. So we're trying to reduce the risk. So generally that age is about 65 that we start thinking about aspirin to prevent heart disease or stroke in women. And usually I even think of women who have risk factors for heart disease. It may not be every woman over 65. And also I would do an assessment of them, though, to make sure that they haven't had ulcers in the stomach or high risk of bleeding in other ways, so we can make sure that we're not putting them at high risk. For men, aspirin therapy, we think about starting at a younger age. The age for aspirin therapy in men is 50, especially men who have multiple risk factors for heart disease. That would be the age, as long as they don't have any, I'm not concerned about the risk of bleeding in them in particular.
And I have chronic AFib, and I have a pulmonologist and a cardiologist who both point fingers at the other one. And there's a war and about the medications. And so I'm the ping pong ball. Do you have any opinions about I realize it's, sort of blind situation, but I'm running off a battery. That's, my heart isn't working on its own anymore. So what kind of outlook do I have in the situation?
If you don't mind me asking, what particular medicines are they having discussions about? Is it the blood thinners?
I'm sorry, what?
Which particular medication for atrial fibrillation are your different consulting physicians having discussions about?
I take over 3 dozen medications every day. And I really, at this point, I take inhalers. And I honestly couldn't remember to tell you all the medications.
I understand.
So I take a minimal amount of heart medication.
Right.
And I suppose I take more lung medication, but the fact is, I'm in chronic AFib, and I can't, I just can't get out of it. So whatever medications I'm taking,
Right.
I'm afraid I didn't bring my list sheet.
No, I don't mean to delve into your medical
No, I know,
profile.
I know. I wish I had, but I didn't.
No. And it sounds like you have a pacemaker, is that correct?
Oh yeah,
Got it.
oh yeah.
So without getting too much into your particular medical details, for those of you in the crowd, atrial fibrillation, as many of you may know, is a condition in which the heart's electrical impulses, which are typically managed by the own internal pacemaker of the heart called the sinus node, is overtaken by fast, erratic heart signals, typically from the left side of the heart, from the 4 veins from the lung that are draining down called the pulmonary veins. The heartbeat becomes irregular. The heart doesn't have the same squeezing mechanism, if you will, and it rather does what it sounds like. It fibrillates. And by itself, if somebody has lone atrial fibrillation, what we are concerned about is the risk of stroke, because when the blood is not squeezed effectively, it can pool, especially in that little pocket on the left side called the appendage, and clots can form. And that risk of a stroke in someone that has no other particular risk factors, and we'll talk about those, is less than 2%. But then once you include other risk factors, and this is a mnemonic that we use, and in cardiology we love mnemonics, our trials are all mnemonics, our risk scores are all mnemonics, it's called a CHAD score. And that score is based on things like congestive heart failure, blood pressure, age, between 65 and 74, and then even more so, more of 75, diabetes, prior history of stroke, vascular disease, and even women. The more points you have on that score, the higher the risk of stroke. And this kind of goes back to what you just were mentioning earlier, was that you are on a set number of medications. So the goal is to not only control the heart rate, because we don't want it to beat too fast, because when the heart beats fast for a longer period of time and irregularly, there is a risk for developing what we call a tachycardia-mediated cardiomyopathy, which is a fancy term meaning the heart beats so fast that it doesn't beat effectively and the muscle can get weak. And that's one aspect of it. But other important the other important aspect of it is mitigating the risk for stroke. And I would surmise that you're probably on a blood thinner as well for your atrial fibrillation. Now, to get to the point about being on a number of medicines and different physicians interacting. third time's a try. Atrial fibrillation can be caused by a variety of things. Lung disease can cause it, thyroid disease can cause it, heart disease from high blood pressure and congestive heart failure can cause it. But that's where I think it's really important, is if you are on a lot of medicines, to make sure that the polypharmacy, if you will, of these medicines isn't causing adverse interaction between the medicines. And that's where your cardiologist, your pulmonologist, and your internal medicine doctors work together hand in hand to make sure that's not the case, but also to make sure that they are treating all the possible reversible causes, and to make sure that they are treating you effectively and they have you on all the right medicines to provide you the best long-term prognosis, but I think equally as important, a good quality of life.
Explain the calcium scoring and what that means, what the numbers mean, please?
So the question was, can I explain a coronary calcium score and what the number means? So a coronary calcium score is a type of heart scan that we do. It's a CT scan of the heart in particular, and we're looking for what we call subclinical atherosclerosis, which is early plaque buildup in the heart arteries before you even have symptoms of heart disease. So we're trying to be preventative. We're trying to catch things before they even give you symptoms or cause a problem. And so this is a test that I'll order when I'm trying to get a sense of what someone's risk is, especially patients who are asymptomatic, meaning you don't have any symptoms that I'm concerned about for heart disease. And that calcium score gives us a sense of how much calcium are you building up in the arteries, because plaque can calcify, and so it's a sign of plaque in the arteries. That calcium score, the number ranges. If a calcium score comes back at 0, that's good news. We generally say that your risk of having a significant blockage in a heart artery is very low. And that might be a patient that I would say, for your cholesterol, let's try to do some lifestyle modification. We may not need to be as aggressive about medications to really try to get your cholesterol down, because it doesn't look like you're starting to form this plaque buildup early. And then there's score that is that we consider low risk score, which would be a score of 1 to 100 or 1 to 99. Generally, we consider that low risk for having some type of significant blockage in a heart artery. We also think about risk as moderate or intermediate risk, and that would be a calcium score of 100 to about 300. And then a calcium score greater than 300 is when I start to say, this is getting pretty high. I'm concerned that you're at risk for having a significant blockage in a heart artery, even if you aren't having symptoms yet. And those are the patients by that score, the ones that are 300 or greater, that I start thinking about doing additional testing. Like I might say, let's do a stress test. Let's get you on a treadmill and really have you exercise with us and see, is there an issue in terms of blood flow to the heart when you are demanding more from your heart? Those are also patients that I'm more aggressive about controlling their risk factors. I would say we need to make sure that your blood pressure is very well controlled. We need to make sure your cholesterol is very well controlled, that we may even say, let's start medications to help reduce your risk. And those are patients that I'd probably monitor more closely. A calcium score can be followed longitudinally, so it can be repeated. Generally, I don't say repeat it once a year. That's probably too frequent to see a change, but every 3 to 5 years, it's reasonable to check in and see, do we see that it's staying the same, or is this starting to get worse with time? And if it's starting to get worse, I would say we're probably not doing a good enough job controlling your risk factors. We should be more aggressive about it. So it really is a way to monitor patients and a way to get a sense of what your level of risk is.
The cholesterol is there building up before it shows up as calcium, is that correct?
Correct. So it can. So the plaque buildup in the arteries, sometimes that plaque becomes calcified, and that's part of the process of atherosclerosis. That's the plaque buildup in the arteries, is that calcium can become calcified plaque. And that's what we start to see on a coronary calcium score. But it's true, as Dr. Tehrani was mentioning during our talk, is that we know that atherosclerosis is a process that starts, and even adolescence, it can start at very, very young ages. And so even though we may not see the effects of that until patients are in their 60s or 70s, this is happening over the course of decades. And so that's part of the calcium score, is to monitor that and see if you are accumulating more plaque over time.
I have a few questions from our online audience, if you guys don't mind. So to both Drs. Epps and Tehrani, the first question is, how would the doctor decide if they should insert stents during the cath, or at which point would it not benefit the patient to do so?
So that's a very good question, and that's a question that Dr. Epps and I ask each other all the time when we look at patients' films that we were taking care of. So the answer is that plaque buildup, when it happens over a period of time, it causes narrowing within the artery. So it can cause what we call a narrowing of the luminal diameter. And we typically know that once that diameter blockage is 70% or higher, that's when there is a higher risk of what we call ischemia. Ischemia is a term by which that reduction in blood flow as a consequence of that narrowing increases the risk for an event. And that can be measured a number of ways. The simplest way is the operator's eyes. And they've done enough of these cases, and their experience, they can give an estimate. But we also know that there can be variation amongst operators when they assess that. And we have ways that we can do it in the cardiac cath lab, in which we can do literally very exact measurements of what that narrowing is with quantitative angiography calculation. We can also do it by passing what's called IVUS, or intravenous ultrasound, intravascular ultrasound, which is a ultrasound catheter over that 0.014-inch wire, and we can literally take a look at the inside of the artery, whereas we look at it from the outside in, as I showed you here, from the inside, and we're able to literally get an idea of what the burden of plaque, clot burden is, and get an assessment. So that's a quantitative way to make an assessment. And the other way we can do it is to do a stress test. So when you guys think of stress tests, you think of a patient on a treadmill, or a patient getting an injection of a medicine under a nuclear camera. But we can also do stress tests in the cardiac cath lab, where we take what's called pressure Doppler wires, and we take them down the coronary artery, and we can measure pressures after the blockage, before the blockage, either at rest, or we can give medicines like adenosine, and we can actually get numbers. And there's been a number of trials in our field, in our practice, in which those numbers have been validated to show that a particular measurement called FFR, or fractional flow reserve, where it looks at the pressure distal after the blockage and before. And if it's less than 0.8, then that suggests that narrowing is significant, and we should consider intervention. So to answer your question, there's a number of ways that we can do it. We can do it visually. We can do it anatomically with intravascular ultrasound. We can do it in the catheterization lab with techniques that mimic stress tests, and they're actually validated by stress tests. And we take all that information, we take the clinical context of why the patient came to the hospital, and then we make an assessment of whether it's appropriate or not. I think the most difficult decision any operator makes was when they're doing these procedures is to determine when is the time that's best not to do a stent, because ultimately we really want to focus on medical therapy.
And generally, when we look at blockages, we give it a number. What % blocked do we think that artery is? And the blockages that are 70% or greater are the ones that we usually think could cause a problem for you, that it's decreasing blood flow to the heart significantly, and it may cause symptoms like angina or chest pain, but it also could put you at risk for having further narrowing of that artery and even a heart attack. And so blockages that are 70% or greater, in the right patient, a patient who we feel is having symptoms from it, or if it's in a location that we think is very important, generally those are patients who would get stents for that blockage. And then blockages that are less than that, we usually think are okay, in the sense that they don't need to be fixed with balloons and stents, but that medications will take care of it. So we would make sure we're putting you on good medications to help prevent that blockage from getting more significant or more narrow on you. And that medical therapy could work very well. Sometimes there's blockages in a 50 to 70% range that we think is borderline, and that's many times when we do test, like Dr. Tehrani was mentioning, the ultrasound test to give another assessment of the percentage of the blockage, or a stress test in the lab where we're actually testing the blood flow to that artery to see, is it really decreasing blood flow to the heart?
Eating peanut butter and eggs.
The question is, what's your recommendation on drinking coffee and tea, and also on eating things like peanut butter and eggs, correct? And eggs. So in terms of coffee or tea, caffeine, I usually recommend that patients drink those in moderation. I know a lot of people don't want to give up their morning coffee or their cup of tea, but the thing that I get concerned about with caffeine as it relates to the heart is generally two things that I worry about. One is blood pressure. So we know that caffeine can elevate your blood pressure, and especially in patients, if I'm having a hard time controlling their blood pressure, I do ask them to cut back on the caffeine so we can see if we see positive improvement in their blood pressure when they limit their caffeine intake. The other thing I worry about is caffeine sometimes can cause irregular heart rhythms. Not necessarily dangerous irregular heart rhythms, but they can cause irregularity in the heartbeat that can really give patients symptoms. And some patients feel like their quality of life is really affected by those symptoms. And those are patients that I recommend in particular that they restrict their caffeine intake as well. In terms of peanut butter and eggs, so I think I wouldn't say that you can't have those. That I think everything is in moderation. We certainly get concerned about foods that are higher in saturated fats, and peanut butter has a lot of calories in it. And so I think that's something to be to have in moderation, as well as eggs. We know that egg whites are higher in cholesterol. That whole eggs are higher in cholesterol, and in patients that I'm really trying to monitor their cholesterol and get good control over it, I think egg whites would be the recommendation there. See if Dr. Tehrani has anything to add to that.
I agree. I think the most important thing you can do is to do everything in moderation. Look at the calories, try to minimize saturated fat and carbohydrates. Try to have almond butter. Almond butter has got less saturated fat than peanut butter. If you're going to have eggs, and make sure to have it in a moderated amount during the course of the week. There is certainly protein, but there's also cholesterol that's with it as well. So I think a lot of these things should be done based on what your risk for atherosclerotic heart disease is, and in conjunction with your internal medicine doctor and or cardiologist, based on what your cholesterol is, what your blood sugar is. But keep in mind, a lot of the things that we eat, peanut butter, we eat it with bread. Bread's got carbohydrates. And eggs, depending on what form you have it or what you have it with. If you're going to have it in the morning with bacon or sausage, keep in mind those also have carbohydrates as well. So it's important to have a diet which really meets the nutritional requirements, but is also going to minimize the amount of discretionary content.
I have another online question. When is it okay for the primary care physician to manage heart disease, and when should I see a cardiologist?
So the best doctor that anybody will ever have is a very good primary care doctor. Those are physicians that know you head to toe, know your entire, all your organ systems and all the conditions that they're managing and you're treating. So I think it's very important, whether or not you have heart disease, to establish care and long-term care with a primary care physician that you trust and you feel comfortable with, that you can open up to, and you can have very honest and very, very good adult conversations with. With regard to how and when an internist can manage heart disease, I believe any patient that has heart disease should have an internist. And I believe that internist should be working very closely with your cardiologist to manage all the risk factors that come out of it. Because once you have heart disease, you've gone from primary prevention to a secondary prevention phase. And you're not only treating the heart disease, but all the risk factors that go with it. And Dr. Epps can tell you, when we see patients of ours that have documented heart disease, either congestive heart failure, or they've had a previous heart attack, what we're focused on is looking at those risk factors that they may have and seeing what we can do to minimize them. So I believe all patients with heart disease should have an internist. That internist should work very closely with your cardiologist to minimize that risk. And in fact, they may be seeing you more regularly than your cardiologist. Your cardiologist may be seeing you once or twice a year, and that internist, based on your risk, may be seeing you 2 or 3 times a year. So that was the first question. What was the second question?
The other question I have is, could you discuss microvascular disease in women? Dr. Epps?
Sure. So when we think about coronary artery disease or the plaque buildup in heart arteries, generally we think of what we call obstructive coronary artery disease. Obstructive means it's a blockage that's significant, that it's decreasing blood flow to the heart. So that the angiogram we saw of the patient who came in with the heart attack, that is what we would consider obstructive disease. It completely blocked blood flow to that heart, or in every instance, it may not be 100%, but it may be 90%, or it may be 75%, something that's blocking blood flow. Microvascular disease is also called small vessel disease. So it's blockages in very small arteries, ones that we can't even see here on this angiogram. So those can certainly cause symptoms the same way as a major blockage in one of the big heart arteries can cause symptoms. And patients can even have heart attacks with those types of blockages. But generally, the treatment for it, rather than the balloon and stenting procedure like you saw, the treatment for it would really be good medical therapy, making sure we're controlling blood pressure, cholesterol well, and then also thinking about medications called antiplatelet therapy like aspirin, or sometimes super strength aspirins like clopidogrel, Plavix, Brilinta. Those are medications that can help the platelets. Those are the blood clotting cells in our body that reduces how sticky they are so that you don't form blood clots. So microvascular disease is more common in women than men. And so women generally, before we started to learn more about this, probably in NIH studies in the early 2000s and moving forward, we started to learn that women were more likely to have microvascular disease. So they would come in with heart attacks, at least based on blood markers and based on symptoms, but then we'd do an angiogram and their arteries would look normal because they had good blood flow in the major arteries. But we started to learn of something called microvascular disease, is that in the very tiny arteries that we can't even see, that patients can have blockages as well. And the way we identify that, sometimes we can see it on an angiogram just by what we would call slow or sluggish blood flow. And also abnormal stress tests. So a patient who has an abnormal stress test and then has an angiogram that doesn't show a major blockage, sometimes people might say that stress test was a false positive stress test, that you don't have coronary artery disease. But what we know in women, especially women who are having symptoms, if they have a positive stress test, meaning an abnormal stress test, and then we do an angiogram and there's no major blockage on that angiogram, for me, I might still say, I think you have coronary artery disease. It's just microvascular disease. It's very small. I can't fix it with the stent, but we can certainly manage symptoms with medications, and we can certainly reduce your risk of having a heart attack with medications. And so that's what microvascular disease is. But it can also happen in men too, and I do have some male patients with it, but it's just that it started to be identified in women more commonly than men. And part of the reason why there's the misperception that women don't have heart disease. It's not that they don't have it as frequently as men. It just may look different in women than it does in men. Yes.
Would you describe a little bit more about what is angina, what causes angina, when
So the question is, and I'm just repeating this for our online audience too, is can you describe more what is angina, what causes angina, and is it how do you treat it? Was that the third part? Okay. So angina is chest pain or discomfort or chest pressure that we generally think is coming from the heart, coming from decreased blood flow to the heart. And that could be from a blockage in a major heart artery, like the woman in the angiogram that we had, or it could be from the very tiny blood vessels, the microvascular disease that I was mentioning. But it is discomfort in the chest because the heart's not getting enough blood flow. And when the heart's not getting enough blood flow, it's painful, it's uncomfortable. And angina can be, I think was the question, managed, or should you be concerned about it? Right. So there's two different types of angina. There's something that we call stable angina, and there's something that we call unstable angina. Stable angina is the type of discomfort that patients describe that's fairly predictable and regular. So they may say, every time I walk up the stairs, when I get to the second flight of stairs, I start to feel the discomfort in my chest. It's related to exertion. And then they say, when I rest, it goes away, it gets better. That's fairly predictable symptoms. And those can be managed certainly with medications like nitroglycerin, which is a very common medication that we use to treat angina, where patients put a medication underneath the tongue. It helps open up blood vessels to the heart or increase blood flow back to the heart, and it can help relieve the symptoms of angina. Stable angina, we can manage with medications. We also manage it with balloons and stenting procedures sometimes as well. If a patient has an abnormal stress test or comes to the office and says, I get chest discomfort when I'm exerting myself or when I'm exercising or when I'm active. Then there's also unstable angina. Unstable angina is what we get more concerned about in the sense that the unstable angina can cause heart attacks. And we think unstable angina is usually due to that plaque erosion that I mentioned in women or that plaque rupture that I mentioned. It's a plaque that's unstable. And the concern is if that plaque, if you have blood clot that suddenly forms in that area where the plaque is unstable, that you could completely block the heart artery and cause a heart attack. And that can cause damage to the heart because the heart muscle just isn't getting any blood flow, isn't getting oxygen, and heart muscle can die that way. So unstable angina, we generally think of as an urgent or an emergent situation. And those patients generally end up in the cardiac catheterization lab with us so we can do an angiogram, take pictures, and fix a blockage or an unstable plaque if we see it. Unstable angina symptoms can occur with activity or exercise, but also we think about angina that's happening at rest. If you get rest symptoms, that's generally something that's more concerning, that you should certainly alert your doctor or go to an emergency department to be evaluated if you're getting symptoms at rest that are not relieved by nitroglycerin.
You mentioned one of the symptoms you mentioned that is possible to have if you have a heart problem is pain in your jaw. Does that generally occur in combination with other pains, like closer to your heart? It seems like the jaw is far away from the heart.
So it can happen either way. So a lot of times patients will describe discomfort that may start in the chest, but they say it radiates, meaning it's moving. So it may start in the chest and move up into the neck or move up into the jaw. I also have patients though who their symptom of angina is just jaw pain. It can happen in isolation as well. And so that is, it's a very good question. It could happen either way, in association with other pain, or it could happen on its own.
Can stem cells be used to repair the heart muscle after a heart attack? I know I heard that years ago, and then I haven't heard anything recently.
Right. So there has been ongoing research studies with stem cells. So stem cells, the question is if someone has a heart attack and their heart muscle dies, right now we generally think we can't reverse that, we can't fix it, we can't repair it. But the question is if we were able to inject these stem cells, could the heart regenerate? I think right now we don't have the answer to that. I think the studies haven't shown that yet, but there may be ongoing research. I'm going to ask Dr. Tehrani if he's aware.
Yeah, this is still an area of ongoing research. There was a lot of interest initially in things like thymoglobulin or thyroid hormone and whether that could regenerate cells. There's also ongoing research with regard to stem cells. We still don't have an answer to that yet, and I think we will have that in the upcoming years. But I think that's something that will really change the paradigm of how we treat heart disease as that becomes more known.
I have a follow-up question from an earlier question that you received a bit ago about when to insert the stent and when not to. And this follow-up question is, you talked about if the blockage is over 70%, typically speaking, then a stent is recommended. But what are the cases in which the blockage is so bad that stents might not be helpful at all?
So that's a very good question. Usually when we decide whether a patient should receive a stent, it's anatomic factors of whether we think that blockage indeed can be fixed and get a good durable result with a stent. But it also takes into consideration, are there blockages in more than one artery? So as you know, there is one main artery off the left called the left main artery, off which comes the left anterior and the left circumflex arteries. And on the right side, there's the right coronary artery. And if there is blockage in more than one artery, and in particular, if it's in the setting of things like diabetes, in the setting of congestive heart failure, and other conditions in which we know that stenting in multiple arteries may not be of benefit, then we'll stop. We'll then take the patient off the table. We will then gather what we call the heart team, and the heart team is truly a team of the cardiologists and the cardiothoracic surgeons, and then we'll make a decision of whether indeed the patient would benefit more from bypass versus stenting. And Dr. Epps will tell you diabetes is the one condition, and depending on the amount of disease there is, especially if there's diffuse disease in more than just one location, that bypass surgery is superior to stenting. And this data goes back 20 years. And the reason we know this is because we're literally bypassing the blockage and bypassing areas which could serve as potential future areas of plaque rupture and narrowing, and that has a benefit. Now, there's also the question of whether there's a blockage in that main artery called the left main artery. And for a long time, that was something that cardiologists walked away from. We said the left main artery belongs to the surgeons because that's a large artery, and if that's stented, it could potentially compromise the other branches that come off of it, like the LAD or the circumflex. And certainly, now to this day, if somebody has left main disease and they have a blockage, certainly we always want to stop first and take a look at bypass surgery. But there's been a number of trials that have been coming out over the last several years. Initially with the Syntax trial, which is a trial that literally gave a score. It's a score that gives a number to the anatomic complexity of the heart disease. And that goes into conjunction with other risk factors like diabetes and congestive heart failure to determine whether stenting is better and with bypass is better. But we have a number of trials that have come out, in particular the Excel trial, which shows that even in patients that may have, what I would describe as intermediate complexity of heart disease, of anatomical disease, calcification, the extent to which the arteries are tortuous, they're calcified. If they are not a surgical candidate, then stenting may be better. So to answer your question, it comes down to a number of factors: anatomical complexity, patient's overall health. Frailty is a big thing that we look at. Open heart surgery is a big deal. If the person may not be somebody that we believe would do well with going on with on-pump bypass surgery, then we'll think about stenting. But then we also want to take a look to see what the extent of the disease is.
That was a great explanation. Thanks, Dr. Tehrani. Do we have any other questions from our live audience at this point? Oh, we do. There's one in the front.
Okay. Over 18 years ago, Ed LaFrac did my left main anterior. It was supposedly 98% occluded, and I'm still here. So, and meanwhile, my cardiologist and my pulmonologist are playing, ping pong. I think I was very lucky that he left one vein that was artery that was 60% occluded, and he just left it alone. So I feel very, very lucky to have had the man making the decision at the time. Yeah. So.
Absolutely. Sounds like you've done very well. You had excellent surgeon. You were in great hands, and so I'm glad that you've been doing well for this time.
If you have plaque buildup, can you ever reverse that?
So the answer to that is there is some ability for plaque to regress a little bit, but I wouldn't say that you're going to go from having a significant blockage to no blockage with certain medications or lifestyle modification. Generally, what I think of when someone has a blockage, what I'm trying to do is stabilize what they have. I'm trying to make sure that that 50% blockage doesn't go to a 70% blockage. And that's with medications like cholesterol-lowering medications and then lifestyle modification. Don't think I'm going to get a 50% blockage down to a 30 or a 20% blockage. There's some microscopic regression. So there's been certain studies that have looked at it on the microscopic level. Is plaque getting better with certain medications like statin therapies? And the answer to that is yes. But I don't think you'll see significant reduction, for instance, if we repeated your angiogram after we started you on cholesterol-lowering medications or after you changed lifestyle. I don't think I'd see a significant reduction on the angiogram.
That's absolutely correct. So I'm going to say something that may sound a little bit provocative, but plaque rupture, in which the plaque literally either erodes or the shoulder by which the plaque is attached to the rest of the vessel, that process happens on a regular basis, and it can happen to any of us sitting in the room right now on a very subclinical basis. And plaque rupture happens, and there's healing, and then that plaque over time becomes the wall, becomes embedded within the wall of the artery. The reason and what happens over time is that the artery starts to remodel. The artery may get larger and may look like what we would describe as ectatic, or may have some periods where it looks like it's got an aneurysm, and that's just where the plaque has become part of the wall of the artery. But we have the benefit of aspirin, we have the benefit of statin medicines, which doesn't make the plaque burden necessarily go down, but it stabilizes the plaque. And what that means is that area or that shoulder by which that plaque is attached by two hinge points to the rest of the artery, if you look at it like a cross-sectional area, like a hose. Imagine you're looking at the mouth of a hose. That plaque shoulder becomes thicker, it becomes more stable, and it reduces the risk for rupture. So that shoulder, what we look at, it's made of a tissue called collagen, a thick tissue. And that number, what we look for is what's called a thin cap fibroatheroma. If that shoulder becomes thick and it becomes organized, which is what statins and cholesterol medicine and exercise and blood sugar control and all those things do, it prevents that from happening. So patients always ask, am I going to go from 70 down to 50 or from 50 to 30 or bring the plaque less? What we tell them is we're going to stabilize the plaque. Plaque is something that exists for a long period of time. The key is to prevent that plaque from impairing blood flow and therefore increasing your risk for a heart attack.
For an otherwise healthy person, so to speak, I know there are ways to modify diet in order to help reduce cholesterol, help reduce plaque, et cetera, and without taking any medications if you don't need them as of yet. I know that fiber can be a good way to help to reduce the cholesterol in one's body or arteries and kind of pull the cholesterol out. How significant do you think that is as far as a good form of diet to follow, and how much should we have as women versus men on a daily basis to help us stay healthy in that regard?
So I certainly think that having fiber in your diet is a good thing. In terms of, and I apologize, can you repeat part of the question? It was...
I was really just asking how relevant fiber is in helping to reduce cholesterol and then, reducing plaque in the end.
Right. So I think fiber can certainly be helpful in reducing cholesterol. Overall, generally what I recommend for patients, I think the best way to reduce cholesterol in terms of diet, one, is rather than focusing on what you're not going to eat, focusing on what you will eat. And fiber can be one of those things. Also, I tell patients plant-based, having really a plant-based diet, so diets that are high in fruits and vegetables, and fiber certainly comes along with that because you get that in fruits and vegetables. But what we've noticed is that patients who have really focused on those in their diet, and patients who have been even vegetarian, we find that they're able to really significantly reduce their cholesterol numbers by doing that. And I have patients who I absolutely thought should be on a statin, and they were committed to lifestyle modification, and they really did increase the number of plants in their diet. And I did see their cholesterol come down to the point where I don't think you need to be on medications anymore. So I think there are certainly modifications that you can make to your diet to reduce your cholesterol level. And the thought is reducing your cholesterol will reduce your plaque burden in the future.